Hey, everybody, this is Eric Mishi, Executive Director with SAVE, Suicide Awareness Voices of Education. All week this week, we've got conversations with folks that are leading conversations and work around suicide prevention, suicide awareness. We just got done having a great conversation with the now 63-day-old CEO of the Trevor Project, James Black. Had a great conversation with James. And now delighted to be here with Deb Stone with the CDC. Deb, great to see you here today.
Great to see you, Eric, as well. Thank you so much for having me.
Well, thanks for being with us. So why don't we start with maybe share with folks a little bit about your background and what the work is that you do with the CDC.
Okay, so to share a little bit of background about me, I will tell you, Eric, that I was thinking about this conversation for a couple days, and I realized that September of 2024, where we are now, actually marks the 25-year anniversary of my working in suicide prevention.
Wow.
Yeah, so
I'm going to say congratulations, and
you.
We'll talk a little bit about not all 25 of those years, but
yes.
a little bit of it.
Yeah, I mean, it's just amazing that it's been this long, but it's really, suicide prevention has really been a passion of mine for so long. And, I love that you put this conversation together, because I think that there's actually a little bit of a misunderstanding. Sometimes there are people just don't know what, working in suicide prevention really looks like. And for example, over the years, if I told you the number of people who I say, I work in suicide prevention, they say, oh, that must be so depressing. Or they say, oh, it's great that you do that. I could never do that work. And, to me, I don't really look at it in those terms at all. I just find it really enriching and inspiring, all the people that we work with and the folks out there who are, struggling and find a way to, who are able to find a way to live, and even thrive after, maybe a suicide attempt or knowing somebody who died. There's so many people out there who have all sorts of stories, and they're, finding a way to go on. And I just find that really inspiring. And, for my own part, I actually started working in suicide prevention, probably like many of us, because of some personal struggles that I was having in my life. And also I knew people who had died by suicide. So I started out, I wanted to be a clinical psychologist, and I was really sure that was, my path. And somewhere around my senior year of college, I learned about public health, and I learned about social work. And so I thought about, the fact that I could actually really make a difference on a population level. And, that was so exciting to me. And so I ran with that and never looked back. I started out doing a internship, a CDC internship, way back in 1999. And I was at the Rhode Island Department of Health for like 2 years. And there I was working to help develop the first state strategy for suicide prevention in Rhode Island. So I've come a long way from the state of Rhode Island to the national strategy. And I also worked with the Harvard Injury Control Research Center and the Education Development Center, long before EDC became the home of the Suicide Prevention Resource Center, or SPRC, as we so well know it today. Mm-hmm. And so I have just, done a lot of work in that space. And then, right after I finished my doctoral degree, because somewhere back in there, I went back to school, I started working at CDC. So I came full circle and came back in 2010, and I've been with them for the past 14 years. So I've been, overseeing a lot of research that's gone on with some of the greats in the field, like Yates Conwell and Cheryl King and others, and it's just been a joy. And, it's challenging, but there's so much, good that's being done.
So I've been in this role for a little over a year, and I will by no means or stretch of the imagination, be able to put 1 year up against 25 years. So here's what I'm curious about. In those 25 years, what has been, in your mind, the biggest changes, positive? Let's start with positive. What have been the biggest changes, positive, in a positive way, in this subject matter space in the work that you've been doing?
That's a great question. I would say that, over the course of 25 years, the field has just continued to grow and grow. And, when I first started, um, it was a really exciting time, actually. And in 1999, folks were, coming together. They came together. I think it was in 1999. It might have been 98. Came together at the Reno conference to talk about putting together the first national strategy for suicide prevention. And so that was such a great time because people all over the country were putting together their state strategies for suicide prevention. It really had not been done before. Some states were, of course, like early adopters, if you will, and had started, like Washington State had started putting those strategies into place early. But for others, it was a great time of activity. And after that, the field, really continued to grow. And we had our second strategy in 2012. And this was really a continuation and such a commitment to suicide prevention. And over time, there's been a lot more funding put towards suicide prevention, not nearly what we need, but it's been great to see that we've been able to expand suicide prevention, be it research or be it prevention programs in states and communities like CDC funds, or be it, now, 988 is a huge success in terms of, really having that nationwide hotline available 24/7. And of course, there was, a previous hotline before that. But it's just been, such a great sense of growth and development. And so many people have been been turned on to suicide prevention and have been, included in this space. And then, in 2024 of this, April 2024, we have our third national strategy for suicide prevention. And it was basically the idea of the Biden-Harris administration and the White House that really asked us to, work on this. So, I mean, to think about suicide prevention being at that level of, that level of commitment and importance has been really wonderful to see.
So as you talk about those three iterations, so we'll start with that. So as we talk about those three different iterations of the national strategy, what makes this strategy much different than the previous two?
So that's a good question. I would say that the first two were really amazing, and they too, like this third strategy, covered a lot of ground. But I think what was so important in this third strategy is what we were really able to leverage a lot of the work that had come before. So we, for example, looked at the older strategies and could see where there were some gaps in the field. And we could see or think about where research had continued to grow, and think about data and all the advances since 2012. So there's been a lot of movement over time. There's been a lot of folks who have been so engaged, and this strategy really seeks to guide and motivate and promote a coordinated and comprehensive approach to suicide prevention for states and communities around the country, and for tribes and territories. And it really builds on the successes of the past, fills in the gaps, and addresses emerging issues like social media and youth, for example. Or it builds on the all of the data science, where we can now work to predict suicide into the future. And it also includes so many of the advances like 988 and comprehensive suicide prevention programs around the country. And it also, what's so great about this is a focus on health equity. So health equity has, been something that was kind of like in our minds, but it's really been in the last several years, like we've really started to put that front and center in the work. And I think we did that with the national strategy. So not only do we have a whole strategic direction focused on health equity, which is brand new, that's never been done before, but we also made sure to weave health equity throughout the entire strategy. So it's not just something, oh, we're going to address it here in this, strategic direction. No, it's a part and parcel of the work. And I think that our understanding about that and our attention to populations that have been disproportionately affected by suicide is going to make a difference, because we have to be addressing those populations, or we're just going to be treading water. So I think that's one of the biggest successes and changes in this strategy.
So we had the privilege of being with you in DC when this latest strategy was unveiled, and there was a lot of conversation about if I recall this correctly, about something that related specifically that, as opposed to just kind of being a document that had a bunch of ideas, that there were now some like actual tools behind that. So explain a little bit how that made this particular strategy different than its predecessors.
Thank you so much for bringing that up, Eric, because I totally failed to mention that this is not just a national strategy, but it also has, for the first time, a federal action plan. So, without an ability to implement things that we know work, and without having some sort of accountability, it's really hard to know whether these strategies are successful or not. And so in this iteration of the strategy, we put together a federal action plan, and we worked with over 30, I think around 30 agencies across 10 federal departments. So we're talking about the Department of Labor, the Department of Agriculture, the VA, the DOD, Transportation, CDC, SAMHSA, NIMH. And, so it's such a wide swath of the federal government that was involved in this, which is just, unthinkable in years prior, that all of these agencies actually have a stake in suicide prevention. And so we asked these agencies that worked with us along the way on this strategy, hey, can you come up with maybe 3 or 4 actions for our action plan? And so you can do the math quickly. We were stunned when we got a federal action plan with over 200 actions. And so I said we had about 30 agencies and across 10 federal departments. These folks put their heart and soul into this. And so it is such a testament to the importance of suicide prevention to know that we have all these actions. So the way it works is that the federal agencies who put together these actions are responsible for carrying them out in the next 3 years, because the action plan is 3 years while the strategy is actually 10 years. And then we're going to re-up the action plan. But it's not just about us at the federal level. This is about communities on the ground. So much of the work that federal agencies do is to fund communities and to provide resources that can drive suicide prevention. For example, CDC focuses on its comprehensive suicide prevention work in states, communities, tribes, and territories. And so we are with, funding, pending funding. So a lot of this is pending funding. We want to, expand that program to all 50 states and territories. And so we are going to be funding those entities to carry out prevention. But also, apart from the funding that comes from the federal government, states and communities can take this national strategy and they can look at their state strategies and they can see where maybe they have gaps in their state strategies and things. I mean, there's over like 70 examples of programs, practices, and policies in the national strategy that they can implement. And there's more than 80 objectives. So there's a lot in there, and anybody could pick it up and find something that suits them and that fits their role. So we're really excited. We will have some more tools coming out, but right now there's a social media toolkit and there's some ideas about how to spread the word. And we will be engaging states and communities through our monitoring and evaluation work that we're actually working on right now as well. So we're in it to provide resources at the federal level, but also to bring in states and communities and the local level into all of these wonderful activities and to help them really reverse some of the troubling trends that we've been seeing over the past decades.
Yeah, and I think that's an important part of that national strategy, which is the idea that in order for it to be ultimately successful, there's got to be buy-in and engagement on a very grassroots level, right? So, the average person on the street, probably, I shouldn't say probably, I would say there's probably a 98% certainty doesn't know that there's a national strategy for suicide prevention, doesn't know there's a federal action plan, and yet 98% of that community is dealing with 100% of the realities of suicide that's taking place in their life and in their community. In Minnesota here and in other states where there are large rural populations, we're seeing a significant uptick in rural suicides, which are factors due to a lot of things: access to health care, stigma associated with that particular community and things like that. So being able to translate that strategy to a really grassroots level seems to be an extraordinary part of what I know that those of you who worked on this know is really important in order for it to be accessible and relatable to the average person.
Absolutely. Yes. So we are, looking forward to bringing this strategy down to the grassroots, like you said, and really leveraging it to make a difference and really engaging all parts of society because this is a whole of society strategy that we've developed.
Yeah. So as you think about the future, right, and it's always important to kind of think about the future while we kind of build on the present with the past. What are the concerns that you have as you look at the numbers today, as you look at the data points today? Are there we talk about underrepresented communities. The National Institute for Mental Health released a report a month or so ago about very troubling data points related to preteens and suicidal ideation that are really chilling information there. So what do you see as trouble spots, risk factors that we need to, as a society, be paying particularly close attention to?
Sure. And yes, there's so many, reports out there to consider and think about and to really mull over. And, instead of thinking about like the areas of concern, what I would say instead is that we know what works to prevent suicide. And so we need to do more of that. And I'll tell you what some of those things are. So, we know that we can actually prevent suicide risk before it becomes a crisis. So we need to work in communities in order to prevent risk before it happens. And so that what that means and what that looks like includes addressing social determinants of health. So, for example, strengthening economic support so people have the ability to not only pay for their basic needs, but to also have a well-paying job, and they have good schools in their communities, and there's stable housing, and there's food, security versus insecurity. And so we need to address the many underlying factors, because we know suicide is a complex problem and there's no single cause, there's no single solution. But let's start in our communities to address some of these factors. Let's, increase our attention to health equity and to making all people feel part of the community, that they can be engaged and are valued members. We also know that things like teaching coping and problem solving skills is really essential, as I alluded to, promoting connectedness, as well as creating what we call at CDC protective environments. Mm-hmm. And what we mean by that is that workplaces are, healthy places to work, that there's policies that allow people to take time off to go get help if they need it, that there's awareness within the health, within workplaces, within community agencies, organizations, and so that suicide prevention is really embedded and integrated within all of our organizations and social service agencies, and all of those community groups. Also, we need to improve our treatment and crisis intervention. So that's actually the second strategy in the national strategy, the community-based stuff is strategic direction 1. So how can we make it so that people understand that it is a sign of strength to get help when you need it? So we, continue to battle stigma that's out there, especially in, certain communities where it's really been something you don't talk about. So, having these conversations is so important. We want there to be coverage of mental health conditions, just like physical health conditions, and evidence-based approaches. I think I better take a drink of water, Eric.
That's okay. You're doing just fine.
Thank you. So, there's been a lot of advances in treatment and in crisis intervention through 988, but we need to have, the whole crisis care continuum be part of the solution, including mobile crisis. And then we need to continue funding research and engaging people with lived experience, and also improving our data systems. So there's a lot of data gaps, and the national strategy really provides recommendations for how to, reduce some of those gaps. And I know we're getting short on time, but one of the things that we mentioned in the national strategy is really the need to build, and it may be unsexy, but we need to build infrastructure for public health and mental health so that we have the best data and the best science. We have the ability to carry out, all of these activities that can really support us. And we need to have people, people with lived experience, people who are engaged to carry out the work. And so there's just, I know I've said a lot of things here, but there's, plenty of work to do. We've made a lot of progress. We have more people than ever engaged in this work, but there's a lot to do. And I think we know how to do it through community-based prevention and treatment and crisis intervention, improved data, and a focus on health equity.
There's a lot to unpack there, but there's a lot of good stuff that would encourage people to go check out. They can check out this live stream afterward and get the links to where you can find information about the National Strategy for Suicide Prevention, learn a little bit about the role that each of us can play in being a part of that community that can help save lives by raising awareness about the issues around suicide and what each of us can do to play a part in suicide prevention. As we kind of close this out, Deb, give me part of what we're trying to close out every conversation with is something that you are most hopeful about as you look to the future in terms of what we're able to do to prevent suicide. What is the one or two things that you look at that give you the most hope about the future?
Yeah, I just feel so hopeful that, suicide prevention has really become rooted in a lot of ways in our everyday lives. And we have this wonderful national strategy that really provides us with so many actions that we can all take to prevent suicide. And I know that, hope and healing are possible. And, we're having these conversations like this today and spreading that word of hope to everybody. And I'm excited for all of what we've got started and where we're going. And I think we're going to make a difference.
Good. Well, Deb, first, thank you for your 25 years of service to not just the subject space, but the country and the work that you've been doing. We have been immensely impressed with this iteration of the national strategy. We look forward to working with you and everybody else that's involved with it, making sure that we evangelize and proselytize and get out there and make people know that this is a living, breathing, working document, not just something to put on the shelf and gather dust. And so thank you for your time today. Thank you for your continued work. And we look forward to continuing to work with you.
Thank you so much. It's been a pleasure.
Thanks,
Take
Deb.
care.
You too. Bye-bye.